So today we are going to talk about willingness to change.
Okay.
How has PT changed over the last 10 years? In what ways and in what ways do we need to adopt new mindset, new tools, new vendor partnerships, new
All right.
resources?
So physical therapy, I've been a physical therapist now 34 years. Hard to believe I've said that. My first few years of practice, we did very little patient billing. And patient paid, and it was the billing aspect of it was easy. There was little pre-authorization, authorization limits. It has changed dramatically over the years. We have seen a significant shift to patient responsibility. To the extent where there has been fair copay legislation discussed at national meetings, at state meetings. We've seen patient copays as high as $75, which is crazy. But the push to patient responsibility, the push with they call them utilization management, but basically administrative groups that's nothing but a third party that's supposed to manage the utilization of healthcare. And all they are do, this is my opinion, but all they're there to do is see how they can support the payer paying less, right? So that leads to pre-authorization, that leads to ongoing authorization, that leads to tiers. So you can be an in-network provider for this work comp network, and because of your utilization, they're going to track how many units per visit you typically send, how frequently you see the patient, what is your length of stay, and they're going to categorize you in tier 1, 2, or 3. All right, based on that 1, 2, or 3, they may say, all right, if you're a tier 3, which is lower, they're only going to authorize 3 visits at a time. But if you're tier 2, they may give you 6 visits, initial authorization. All of this change has demanded that practice owners and administrators adopt a mindset of how do we change to fit the requirements. What do we have to do to stay in front of the administrative challenges as opposed to fighting it? It's frustrating. It is frustrating to no end, and I will preach to the choir as long as you let me. But at the end of the day, it comes down to the choice of what are we going to do about it?
Yeah.
How are we going to coach our teams, coach our front office, and coach our staff about this is the requirement, as much as we may or may not like it, as much as we don't agree about it. How are we going to manage it day to day in the office? So what I'm preaching on today is adopting a mindset of being willingness to change, walking in the door every single day thinking, what can we do differently today to be more efficient and be better, as opposed to stuck in the mindset of, but we've always done it that way. Or when someone gives you an idea of, well, you can do X, Y, and Z, or there's this new technology, avoiding yeah, but. All right, there's probably TED Talks out there on yeah, but mentality. Don't be the yeah, but person. Be the what if person. All right, what if we did X, Y, and Z? How would that change? How would that make that better? How would it make the customer experience better? If we're better managing authorizations, yes, it helps the business, but you know what? It helps the patient experience. It helps eliminate patient disruption of care. First and foremost, all this is, and generally what's good for the patient is also good for business. They do correlate. So developing that, encouraging conversation among your staff. One other thing that I think is vitally important, I have heard many practices feel like they want to insulate the clinicians. I don't want the clinician to have to worried about authorization or anything else. I have a different opinion. I believe the clinician deserves and actually benefits from understanding what insurance is requiring of the practice and of the patient. It helps the clinician understand the entirety of the plan of care. So the clinician should be involved in understanding the patient. Well, we've only got 3 visits. We've got 3 visits authorized. Based on my evaluation, clinically, my best recommendation is probably 3 visits for 2 weeks a week. 3 visits a week for 2 weeks. That's 6 visits. And generally after that, we want to kind of ratchet you down, and we're going to probably recommend 2 visits for another week, and then maybe 1 visit for the week after that. So we're talking 9 visits over the course of a month. So I'm probably going to need to get additional authorization. And if we don't get that, or if they don't respond, I'm going to keep you informed. Inform your patient of the hurdles. It's their insurance. They should own it. They can actually even participate, particularly if it's an employer-sponsored plan. That person can go back to their HR person and say, we're not getting authorization. I can't go. I need to get back to work. I need to be able to do this. I pay for this insurance. This company pays for insurance. Get the employer HR person who pays for their portion of insurance. Get them involved, and you can only do that by involving and keeping the patient educated. Taking a breath, but it all goes back to fostering a mindset of being willingness to change. What can we do differently? Not being stuck in your ways.
He said he was taking a breath, you guys, but then he kept talking.
Sorry.
It's okay.
That was my soapbox.
Let's talk a little bit about how has PT changed over the last 20 years, and with all of that change, what do clinic owners kind of need to know? I wrote a question down. Why do owners feel like they're working hard and still always chasing reimbursement? And is some of that a little bit of that mindset shift that you talked about? And how has it changed over the last 20 years? They can't just fill their clinics up, right, with patients.
Right.
What are some of the workflows, mindset, vendor partnerships that need to change so that they can successfully run these practices?
Right. I think the largest category of change is administrative burden. And so much so, there is one reference that I'll give our folks is called SPARC, State Payment Advocacy and Resource Advocacy Consortium. SPARC, SPARC, is a resource developed by the private practice section of the APTA and the APTA. And website, I'll need to look up the site. I think it's actually...
I will link it in the show notes.
Thank you very much. Administrative burden encompasses a lot of things, but it is such a large topic in and of itself. It has a separate category on that website, and it gives you resources to address the administrative burden. So administrative burden, we just talked about utilization management, initial authorization, pre-authorization, visit limits, tiers, all those type of things. How do you manage that? It is frustrating, but the way it demands change at the clinic is you must develop standard operating procedures. This is how we do it at Jim Stoker Physical Therapy. This is how we work. When a patient comes in, X, Y, and Z. This is what everybody does. This is what everybody says. This is how we communicate to a patient. This is how we explain benefits. Benefits, as much as we understand benefits are patient, it's their benefits. They should know it. Many of them don't. So as a service, we can explain what their benefits are. So you establish the expectation from the very minute they walk in, before they see the PT for the first evaluation. So when they check out and your front office asks them for money, instead of saying, you're good, they're going to ask them for money, and they're going to schedule. they're asking for what they were expected to hear. They've already heard what they're going to need to pay because they were explaining that front end. So I think administrative burden has changed, is probably the largest one topic of ours. Physical therapy has changed from a business perspective. Your other question about why owners feel like they're working and they're just constantly chasing reimbursement is it does feel like a chase. You just don't send a claim and the money just comes back. So the administrative burden is a hurdle. Denials are much higher rate than they ever used to be. There is a demand on the front office to do everything correctly to get a clean claim out the door. Even when you get clean claims, you're going to get denials back. How do you address those denials? So you are chasing, and it's frustrating. But the best way to combat that, again, standard operating procedures. When you have procedures, you can track what's our biggest denials, what's our most common denials, and then you develop a strategy to address and minimize those denials. What can we control at our front office, from our intake to diagnosis code usage? One common challenge, and feel like they're chasing, is we get denials for incorrect diagnosis code. Many people put the medical diagnosis on the diagnosis code. That's not what we're treating. We're not changing osteoarthritis of the knee. They've got osteoarthritis. We are treating knee pain, abnormality of gait, etc. All those functional diagnoses. So you want to put your functional diagnosis first on your physical therapy claim. You can, if you, for whatever reason, you feel like you have to list a medical diagnosis, you can. You also want to be as specific as you can. You want to choose, if the code has right or left, you want to choose right or left. So developing those standard operating procedures are going to create less chasing down the road.
Mm-hmm. My next question is, when it comes to declining reimbursement, which is a big topic of conversation, right? Is working aged AR and collecting patient balances more important, in your opinion, or less or equal to marketing for new patients and trying to fill a clinic?
I always believe that the first priority, if any practice owner, if you're going to look at, if you're, let's say you want to develop a strategic plan, where's the opportunity to improve? How does my practice get from point A to point B? Step one is, what can we control? Look internally first. What can we affect within our four walls? Then, once you kind of get those standard operating procedures in place, and you've kind of dialed everything within your four walls, then you can start looking outside. So maximize the business that's already at your doorstep and in your door first. That's your easiest return on investment. So standard operating procedure for collecting, so you don't have HDAR. Standard billing rule has been, if a patient responsibility walks out that door, you probably kiss 50% of it goodbye. You're not going to collect it. I've heard that for my entire career. Again, way too long. But focus on what you can do first. Collect up front, collect every day, establish payment plans so when a patient receives a statement, it's not a surprise. It may be a big number, and that's okay, because PTs are valuable. We're worth it. Don't be ashamed of the cost. You provided a tremendous service that is extremely valuable, that is helping these individuals get back to the lifestyle that they want to. Is valuable. It's a big number. Help them management on the front end so it's not a surprise on the back end. That's where dissatisfaction and frustration and anxiety from a patient occurs. That minimizes your AR. Our AR goals, 90 days, and older AR, 15% or less of your total AR. And our clinics that really have their systems dialed in on the front end, best practices, is well below 10%. We have many folks that are 90 day and over AR is in single digits. And they have very, very little patient responsibility over the top of that. They have this processes dialed in on the front end, and so we're minimizing denials everywhere you can. Then you have kind of a parallel track. Then you can focus externally. Your question about marketing, developing relationships in the community, direct to employer, physician, cash base, marketing direct to the consumer. That's externally facing. Focus internal first, so you've got the engine running when you start pouring more gas in it.
That's right. All right, let's talk really briefly about intelligent revenue cycle. So, what does intelligence and revenue cycle paired together for an intelligent RCM? What does that mean? What does it actually mean? What is the current capability that we have to produce intelligent revenue cycle at MBC? And then my question that you're going to answer at the end is, can RCM intelligence fix bad inputs?
Oh, well, so my first thought as you're asking that question is there is a difference between artificial intelligence and human intelligence. So we'll define that. It has to be a combination of both because at some point there has to be an input. There has to be a human inputting information so the AI can do its job. And so you've got to balance both of those. So in regards to, most people think AI or intelligence, artificial intelligence, the technology is changing so rapidly. Within the last year, even within the last 6 months, we are constantly monitoring different vendors, different services as that continues to develop. How can we leverage new technology to improve efficiency, to improve speed, and to improve accuracy? And that goes right back to my very first soapbox is you got to walk in the door every day with the understanding of I don't know it all. What can I learn today? What can we do differently to be better today? And artificial intelligence, AI technology is one of those. So there are many points along the way of kind of the life cycle of a claim that artificial intelligence and technology is drastically improving things. The first and foremost that I'll just speak specifically about that the clinics can really impact is verification of benefits. And that's kind of, it's garbage in, garbage out. We all know that saying. But if you just focus on clean, detailed verification of benefits right out of the gate, it's going to dramatically help everything. You're going to have less issues, less things you got to correct down the road. And again, standard operating procedures, entry, for example, the number one thing you can preach to your front office is everything they enter into your EMR, whatever EMR that is. Whatever you enter in the EMR, when you establish a case, it must be exactly like it reads on the patient insurance card. Middle initial has a period or doesn't have a period. Does it have a junior or does it not have a junior? What's the spelling? I saw an email this morning. We had a claim denied because William was spelled William. That's how you spell William. Well, it was denied. Medicare has William spelled William. That's crazy. It's crazy. Spelling the name. There are very unique name spellings. My sister's name is Jamie, Jamie. Well, I work with a person in our team that's on our verification team, Jaime. It matters. That's the difference between 30 days of getting paid.
Yep.
That claim denies. We've got to fix it. You've got to send it back out. Then you're pushing your money down the road, and you're paying someone else to fix it when they could have been solving another problem.
Yeah. So that problem could have been solved at the front desk.
Correct. So, sorry, I got sidetracked. Your question was about intelligence.
It's okay.
Artificial intelligence and technology can now take that information instead of a human calling, going to a website, going to the Blue Cross Blue Shield website, going to Medicare website, searching this patient's name, scrolling through the 20 pages of benefits, because when you do this benefits, you're going to get benefits for primary care, for inpatient, outpatient, skilled nursing. You got to know the right place to look. It's got to find physical therapy. Sometimes it says rehabilitation. Technology does that now. You enter information, many technologies will integrate with your EMR, and when you click new patient, whether it's called new patient or something, that technology queries your EMR, pulls it, sends it out, gets the benefits, populates it right back. So it helps solve the issue of, we want to verify benefits and provide financial information to the patient before they see the therapist for the initial evaluation. Technology can help that dramatically. All right.
And then RCM intelligence, let's talk a little bit about the intelligence that we have access to through RCI at MBC.
Right. So we've employed a system that sits over the top of all the practice management systems, EMRs, whatever. We work with, Prompt, Clinician, Optimus, Raintree, WebPT, I'm forgetting TheraOffice. I'm forgetting probably a couple. But anyway, this is a revenue cycle intelligence system that we pull all the information into, and it prioritizes denials. So it tells you, okay, if you get a denial for coordination benefits, the one I just mentioned, that's a quick, easy fix. Bang, put it right at the top of the priority. Get that done, boom, fix it back out the door. Common denials KX modifier. Denied for the KX modifier, put it on, rebill it, get it right back out to Medicare. So that's one of the primary workflows of this revenue cycle intelligence. And there's a lot of platforms. There are workflow platforms that identify the most common denial reasons. They give you that visibility. There's also platforms that are developing where you can write rules engines to where, if this claim is denied for this, then do that on the claim and send it right back out. So the visibility to aggregate your denial reasons, prioritize the workflow, speeds up payment and rebills dramatically. Historically, you had a lot of strategies how to work an AR. Do I go oldest? And but do I go the biggest, oldest? Do I go smallest? Do I go primary? Do I go secondary? It was kind of like you had a clinician's different opinions about how to get rid of swelling in the knee. You got a lot of opinions. This intelligence now kind of takes the guesswork out of that. It gives you that priority. It gives you the roadmap to the fastest, most efficient way to fix that denial, rebill, and get paid.
And so that's why, if you are a practice owner and you are considering a vendor partner to help have the mindset of, we want to do better, we want to do our best, we want to be a best performing clinic, we want to have a partnership in the industry with a revenue cycle management company, this is why you would choose MBC as that partner, because we are innovative in the way that we're constantly walking in the door and asking ourselves every day, right? What can we do better?
That's right, every single day. And we do that through transparency. Excuse me. You can only ask the question and truly get better if you know what you're doing now. If you know your numbers. We review numbers every day. Again, we mentioned the revenue cycle management platform gives us that transparency as to where the denial's happening. We need to know what's occurring to understand where can we improve. And that kind of gives us that roadmap. And we're constantly strategizing, much like I was encouraging each clinic office to strategize and where they can improve also. And that's where we enjoy partnering with offices. We give you the transparency of where your denials now, where are the pitfalls, and support coaching you support developing procedures with your front office to coach your front office, employing new technology, electronic patient statements. If you're still sending paper statements once a month, you're probably in the minority. We're working with all of our clients now to walk through and implementing electronic statements. So patients are getting real-time information about their balances. That's transparent. Patients like it. It's faster. They're not waiting. And they have that visibility to what their statement is now. So that's also taking advantage of technology and transparency.
Yeah, absolutely. It's one of the things that we, encourage all of our clinic partners to do is adopt and implement as many electronic formats as possible in
Correct.
order to speed up payment, get paid faster, get paid more efficiently, and have all of the answers right in one place electronically.
Yep.
And then last thing that I just wanted to say is we do have a case study on Inbox Health where we had a client who went right from daily deposits increased significantly over 3x when that patient statement solution was implemented.
Right. Very true. It was a very traditional office, well known, well established in the community. Everybody knows everybody. And so there was a real comfort, excuse me, people would leave and the front office was so nice. Oh, you got a $20 copay. Okay, you're good. We'll get you on Friday. People forgot their checkbook on Friday. That's okay. They see them Sunday in church. Oh, well, I'll get you Monday. And it snowballs. But when you employ the technology, use the technology, and most importantly, explain it to the patient to start with. This is how we do things. This is how you're going to see your balance. There's not a surprise. And it absolutely helped them increase their weekly deposits dramatically.
Well, MBC is always willing, all of our account managers, myself, Jim, we are always willing to have conversations with our clinic partners where we help them implement these strategies, right? Where we can help them get access to the tools, but then also help them strategize how the front desk is going to share the tools.
Yep. That's the best part of my day. When I get to talk with a clinic owner or the front office about how they're doing, how they're performing, and how we can help them improve and game plan, that goes right back to me as a core PT. I would much rather talk to a clinic practice owner in their front office than be on the phone with an insurance company or negotiating something there. That's the fun part of what we do.
Yep, absolutely.
Yeah.
Cool. Well, this all sounds great. I will link Spark in the show notes for anybody that is listening or watching this video, and we'll be back next week.